Good morning. I'll be talking about a case report about the lower extremity prosthesis. My name is Jetronel Sinric E. De Leon, and let's begin. So, case report is about Miss Nami, a 55-year-old married woman, a teacher by profession. Client presents with below the knee amputation, secondary to diabetic foot ulcer. She is a known diabetic with a familiar history of diabetes. Client is also hypertensive and reports symptoms of consistent with diabetic retinopathy. She visits an endocrinologist for diabetes control, an ophthalmologist for treatment of the diabetic retinopathy, and she chooses antihypertensive drugs for blood pressure management. Amputation is secondary to the diabetic foot ulcer, and amputation surgery was at the transtibial level of the right lower limb. She complains of phantom limb pain, a sharp feeling usually experienced at cold temperatures, which has lasted for 3 months after the amputation. Client goal is to regain mobility with prosthetic limb, increase independence and confidence. Range of motion at the knee joint is normal, good skin integrity, good muscle strength, stump is distally heavily padded, sound contralateral limb, and good upper limb function for doning and doffing for prosthesis. Clients has no other impairment except for the amputation on the right lower limb. Her environment is in a rural environment, and the major form of transportation is with the use of a bicycle a bicycle. This limits her mobility as as she cannot ride with a disability, but she has a good support from her family. So let's continue. So what is the design prosthesis for the condition of Miss Nami by the rehabilitation team? So the chosen socket was a patellar tendon bearing socket. Why? Because it was given because the socket can be modified to accommodate the follow-up changes that could transpire in the residual limb. The patellar tendon bearing socket could also easily relieve stress in areas wherein there's a presence of sensitivity. So that is where the changes in the socket could be done in here. So modifications. So sensitivity on the residuum or residual leg, which the total surface bearing socket would have a difficult time addressing too. So uh, simply speaking, this kind of socket is easier to modify. And let's talk about the stump of the patient. So bulbous stump, shape where the distal size of the stump is usually larger than the proximal size of the leg or construction of the and this is where the construction of the PTB socket, an inner liner and outer liner hard socket allows for build-ups to be applied to the inner liner, allowing easier doning and doffing for an amputee with the bulbous residual limb. So meaning a big residual limb or the stump of the patient. So you can modify this to fit the stump of the patient or follow up enlargements or shrinking that could transpire in the healing process or usage of this socket. So let's talk about the the prosthesis itself. So the parts are the patellar tendon bearing socket up here where the residual limb is uh, put under or and placed, and the endoskeletal body where it holds the residual limb and the socket along with the pylon which connects to the sock foot. So this pylon is aluminum, so it is lightweight and durable. And it uses a static ankle joint, which means it does not move, and a sock foot. So don't let it uh, mis- don't mistaken that the sock foot cannot function as in all phases of the gait, because in spite having a very simple design, the sock feet respond to functional necessities in all phases of the gait. So characteristics of the patellar tendon bearing socket. The weight bearing takes place on the patellar tendon. Easy to clean. Suspension is generated by a belt that is tightened around the distal part of the thigh. Contours within the socket does not wither with use. And benefits of using this prescribed lower extremity prosthesis: that it's lightweight, durable, inexpensive, low maintenance, fairly cosmetic, and easy to don and off. And another thing is that amputees are grouped to traumatic or non-traumatic. So our patient, which is a diabetic, so her amputation is secondary to her diabetes. What is that? The diabetic foot or the diabetic foot ulcer. So secondary to that, which means it is a non-traumatic type of amputation. So diabetes is the leading cause of non-traumatic lower extremity amputation. So just to keep that in mind. So treatment and rehabilitation for the patient would be, so let's start first at the pre-prosthetic training. So stump care, so cleaning and gaussing and trying to shrink the stump. So stump shaping or shrinking before the fitting of the residual limb to the socket, followed by casting to get an impression of the stump. So it needs to be taken care of, and after that you cast the stump so that you have an initial size or shape of the contour of the residual limb, so that is where the shape of the prosthesis will come from. So transfer training would be given to either caretakers of the patient or caregivers and custodian or guardians, or you can also give this to the patient itself, because she is more than capable of using her upper body to transfer herself or to use an assistive device. And another one is that gait reeducation, teaching the patient to stand up using the prosthetic limb and also to step with the prosthetic limb. So that is the first steps on gait reeducation to the patient who just gotten her prosthesis. So with the use of assistive devices like a crutch or a cane would be a good starting point, or with the use of parallel bars. And it also trains the patient for cueing on standing and walking, and also strengthens the sound leg along with the residual leg or the damaged leg or affected leg. So let's move to post-prosthetic training. So in the post-prosthetic training, this is where the initial training progress. So 10-meter walk test, so that the patient walks and you time her progression from point A to point B. In doing so, you check the progression in wherein the patient can handle herself with a cane or without a cane, just using the prosthesis itself. So progression for such training is gait training progression with strength and endurance training. So strength and endurance training is incorporated in the gait training. So using the stairs, climbing up a slope strengthens the leg and endurance of the patient, and also teaching about the importance of cleaning, maintenance, and overall use of the prosthesis. So this is where it's also counseling partake, or teaching the patient that taking care of their prosthesis would be a very important matter, because that is the extension of their body. So next, so other intervention are diabetes medication for the diabetic patient, blood pressure medication, counseling for the changes in the activities of daily living, because it would be difficult for a patient to grasp the idea of using a prosthesis and doing her initial or prior jobs or the ways that she's been doing before. And cognitive behavioral therapy, so that to check if the patient could still be a could still function properly and does not depress or get down. And you can use a support group in doing so, so that she would have a um, more experience and more support for her use of the prosthesis. In doing that, we get her trust, and um, we raise her morale in using the prosthesis and independence. So thank you. That's all.